Okay, I'm going to go ahead and get started. Again, my apologies for starting a little bit late. Um, Part of the issue, we had done a little test of my sound with a larger Zoom call about a week ago, and it worked okay. And then we just tried it when people got in the waiting room, and my sound went funky again. So we do have a backup plan if for some reason my volume presents a problem again today, like it has before. Mel will be able to step in just temporarily to get us started while I try calling in another way and continuing from there. So my apologies. I don't know why Zoom is not a friend of mine. So with that said, please let me know if the volume starts to be a problem again so that I can promptly pause and try to problem solve. Um, with that, good afternoon, everyone. My name is Mariana Sears. Still a little garbled, I'm seeing. Okay. If it's more than a little garbled, let me know and I will dip out. And again, my apologies. So my name is Mariana. My pronouns are she, her. I am a safety net licensing manager with the Behavioral Health Administration. And my goal today is to walk through residential services in the fourth edition of the ASAM criteria as part of our transition process into this updated standard. All right, I am seeing that people cannot hear. So Mel, I wonder if you might be able to step in and walk through the next slide, which is the agenda, and I'm going to try calling in on my phone to see if that sound is better.
Sure thing.
Okay, thank you.
Hi, everybody. I'm Mel Tyler. I'm the Safety Net Unit Manager with Behavioral Health Administrations. My pronouns are she, hers, and I have been helping Mariana in this ASAM 4 project. And we have a very exciting agenda built for y'all today. We're going to go over a couple housekeeping items. We're going to do some initial level setting, talk about why we're here, how we got here, so covering all of the what, why, whens, and hows. Then we'll move into future state residential continuum of care. We're going to go through what the new ASAM requirements are. So talking about what is applicable to all those 3.1, 3.5, and 3.7 levels of care. And then we'll walk through the differences between those requirements for 3.1, 3.5, and 3.7. We'll have some time available for questions, and then we'll cover what next steps are. Mariana, do you want to roll to the next slide? Perfect. So we have a full 90 minutes together today. We are recording this event as we want to make sure that this information is available for those that are not able to make it today. So that will be posted up to BHA's YouTube channel shortly after we're done here. We are going to talk about participation options for those of you that are here. So please make sure that you're participating. We want to hear what your thoughts are as we're going through all of this. We want to hear what your questions are. So feel free to raise your virtual hand. You can come off mute, utilize the chat feature. We'll be making sure and monitoring that. And then also those buttons are accessible towards the bottom of the screen there if you do wish to participate. Mariana, were you able to call in? You're on mute. We can't hear you. You're muted.
Can you hear me?
Yes, we can.
Okay. I'm getting some kind of mixed messages. It sounds like some can hear me fine, some cannot. Hopefully this is better. Same thing, let me know if it's a problem, but I will go ahead and take over. Thank you so much, Mel, for hopping in and helping me out with that little issue there. So, okay, so as mentioned, we're going to go ahead and use this opportunity to step back and do a bit of level setting so that this can be utilized as an alignment tool going forward for providers who can't necessarily be here today, or if there's anything that comes up that we need to revisit. We want to make sure that everybody's starting with the same level of knowledge and understanding. So a little bit of the what, why, and how. So right now, the state of Colorado is subject to the third edition of the ASAM criteria standards. That third edition of the ASAM criteria is no longer considered the most current standard. And the reason for that is the fourth edition of the ASAM criteria was released in the fall of 2025, or sorry, 2023. And so what we are discussing right now is Colorado's efforts to position to align with that fourth edition of the ASAM criteria. And specifically, we're talking about the adult volume of the fourth edition. There's going to be multiple volumes that are part of this ASAM fourth edition, including adolescent services, criminal justice involved, and behavioral addictions, which will be rolling out and released over the next few years. So another part of the why, when we're looking at what we're transitioning to here, we have statutory requirements. We want to make sure that in order to be aligned for funding and reimbursement models, as well as to be in alignment with our statutory requirements, that we are following a national best practice standard and ensuring that we're developing our behavioral health services in aligned with that highest level of care. So for that purpose, we have our statutory references here in case you want to look at those, as well as want to highlight our 1115 demonstration waiver, which is for the entire state of Colorado to ensure that we are in alignment with substance use disorder treatment service expectations, and that we are positioned to be able to receive federal reimbursement for Medicaid services. So very important to make sure that we keep moving forward in that direction. Another part of the why is really this is the national best practice. This is something that the fourth edition had a very rigorous methodology to really move forward behavioral health services, especially considering the last update was in 2013. A lot has changed since then, and a lot of progress has been made, and we want to keep abreast of all of the best practices and make sure we're moving forward in alignment. And really, we're hoping to take this opportunity as a way to grow and to strengthen the behavioral health system and lay that foundation to continue providing the best possible care for citizens of Colorado. So part of the how that we want to emphasize here is really making sure that it's clear who's doing what and what that's going to look like going forward. So the leads in moving this transition forward for the rule changes, right? Making sure that the process that we're discussing here and now and getting that aligned into our BHA provider rule is going to be BHA. And right now I am the one who's helping to lead that forward, but we do have a team of folks that are absolutely part of that process. And then on HCPF side, or healthcare policy and financing, their efforts are going to involve aligning with BHA to make sure that we're moving forward and reviewing and aligning rates to make sure that they are situated and reflective of a sustainable system going forward. And they are right now poised as our main transition ambassador programs with the with our vendor that's helping with our transition ambassador program, which is meant to provide a lot of the technical support, knowing that there's a lot of transitions that are happening and agencies need more support and resources. And one time they are helped by HCPF to make sure that we are moving that project forward. Okay, so let's take a second and look at the how did we get here, right? Again, level setting, what happened, how did we get to this point? So going back in time, January of 2023, ASAM announced their plan to transition into the fourth edition, allowing people to be part of that process and provide feedback up until that point. In July of 2023, Colorado, if you go back in our memories to where we were at that point in time, there was a lot that was going on in our state. We were in the process of transitioning over to the behavioral health entity licensing structure, which in and of itself was a really significant change. So Colorado as a state announced at that time that we wanted to proceed with into the behavioral health entity license process, remaining under the third edition of the ASAM criteria, essentially delaying our transition to the fourth edition standards to a future dedicated rule process. Make sure we did not try to take on too much at once. Going forward a few months, in November of 2023, ASAM released the 4th edition of the ASAM criteria, again, volume 1 focused in on adults, and that then became the national standard as of fall of 2023. Going forward a few months, January of 2024, our updated provider rules were able to take effect, again, leaning into the 3rd edition standards and continuing that until we can move forward into the 4th edition standards. We did implement a delayed enforcement period from January 1st of 2024 to July 1st of 2024, recognizing that the early adopters that were transitioning into that BAT license structure needed a little bit more time to lead into that. And we are hoping to repeat that process going forward, which we'll talk about here in a second. And then June and July of 2024 is when, in partnership with Healthcare Policy and Financing and the Behavioral Health Administration, announced our targeted date for full alignment as of July 1st of 2026. This date was selected for a number of reasons. One of the reasons is to make sure that it was in alignment with the renewal of the 1115 SUD demonstration waiver. Again, very important for our ability to remain in alignment with federal funding requirements and to ensure that we have a reimbursement model that could be sustainable, as well as aligning with the state fiscal year. So we're going to go ahead, and that is where we were. And now we're leading into where we are and where we are heading. So we are currently somewhere between the winter and spring of 2025. So we are in the point where we are working on rule drafting, looking at statutory requirements to make sure that we have everything in place that will support this transition. We're kind of moving a little bit between this first bullet point and the second one because this is not necessarily a straight linear process. A lot of this does overlap and is done kind of concurrently. So we're also in the process of engagement, which is part of what we're doing here today, really providing an understanding of what the transition needs to be, what those expectations are, and helping to move this forward as seamlessly as possible. And we'll talk in a little bit more detail about what that engagement is anticipated to look like over the next few months. And hopefully a number of folks on this call have seen this transition timeline before. Hopefully it's repetitive information. And again, if it's let me know if I'm going too fast or if I need to go into more detail about anything else. One of our important milestones that we are working towards is feeling a little bit just around the corner, July 1st of 2025. That is when our behavioral health administrative service organizations, or BASOs, will be stood up. And we need to make sure that we are aware that we are 1 year away from that full effective date for transition into the 4th edition criteria. So our goal with this engagement and getting all of these rules drafted and in place and community engagement and getting feedback is to be able to support going to the State Board of Human Services in fall of 2025. Again, this is a traditional rule process. It's going to require those 2 reads at State Board with public comments accepted and responded to as they typically are. So our plan and our hope is to be able to follow this process and have these aligned BHA provider rules take effect January 1st of 2026. As mentioned in the last slide, our hope is to continue the delayed enforcement type approach, knowing that those early adopters from January 1st of 2026 to June 30th of 2026 might need a little bit more support in that initial transition. So taking more of a technical support approach, except in the case of health, safety, and welfare concerns. And then our end goal that we're moving towards is full alignment as of July 1st of 2026. And again, this would be all of it, right? Making sure that our funding and our reimbursement model is fully compliant with the 4th edition of ASAM. Same thing with all of our certificates and BAG endorsements and levels of care. Okay, so this is a little bit of a dive into what we have plans that are in progress. Again, keeping in mind that these are where we intend to head, and we will provide information as we're able to really kind of solidify this. But where we're at right now, February, this month has been really residential focused. And so today's call is really focused on those general residential expectations. We also were able to work on kicking off the the transition ambassador program that's going to be assisting specifically those 3.2, which are management and health providers who are going to be more significantly impacted as they transition to the 4th edition of ASAM. So more information will be coming about that particular program soon. We're very excited for it. March is going to continue in the residential realm, but going a little bit more into our criminal justice involved programming. So I can see we have a number of Department of Corrections folks that are on the phone here, as well as some of our DCJ involved or community corrections involved residential providers. Some of the information today, this is a really good foundation for where we're going to need to go, but please keep in mind that we will be looking in March in particular at those criminal justice involved residential programs, as that's a little bit different, and we need to make sure that we're addressing those concerns and challenges in a unique space. So we also have on March 25th, we have a at noon that will have all the links and everything that's posted at the end of this, but it's on the BHA Laws and Rules website, and we are officially going to focus that time on closing, kind of wrapping up the discussion that we've had around the concept of formalizing withdrawal management within the crisis system. You know, there's a lot of questions and needs that are still present with that, and March 25th, that noon call is what we're intending to be kind of our final wrap up for that before we have rule language to respond to later on this spring. So April is going to be hitting the ground running with finalizing the rule drafting, resource development, really trying to lay the foundation to be able to have this more targeted engagement with communities. May and June. So both of these, we have an asterisk next to them. They are intended to be our formal rule feedback period, where we will be openly accepting that responses to the rule language that will be presented at that point, knowing that we're still taking all the feedback that we're getting now and incorporating that into the direction that we're going. So we want to keep the feedback coming even in advance of that. Right now, what we are targeting is the month of May. We mentioned before looking to partner with our regional engagement specialists from the Behavioral Health Administration to really help focus on more targeted community-focused events. Again, those particularly 3.2 withdrawal management involved communities that might be impacted. Those are the ones that are coming to mind as really trying to be present and embed ourselves within that community for some more targeted stakeholdering and engagement. With that said, we're hoping then to go into June, focusing on larger community engagement events and rule processes. So, and I do have, we're trying to be mindful as much as possible. We don't want to exhaust our community providers and these engagement opportunities, and recognize that this is one of multiple efforts that are happening at the same time. So we're really trying to tap into other areas where you might already be connecting with the BHA, potentially through community conversations, looking at the BOSO structure that's going to be stakeholdered and discussed in June. So we'll try to embed ourselves wherever we're able to do so, so that we're not exhausting everybody. Then we're targeting July for feedback integration, August for legal review, and then September for first read at the State Board of Human Services. So feels like a lot. Hopefully we can start to, as we move forward, take this off in kind of bite-sized chews, so that we are able to move this forward. Okay, so let's go ahead and I'm just doing a quick check to make sure my sound looks okay. I don't see any messages that it's not, so that's exciting. So let's keep going. So we're going to talk through changes that are going to be applicable to all levels of care in the 4th edition of the ASAM criteria. Okay, so one of the things that I'm going to try to do as we walk through this is really highlight if there are places where we already fairly well positioned to be able to build into this updated expectation, because we need wins wherever we can get them. And hopefully by the time we're done looking at some of these, we'll see that there are a number of places where we are actually very well positioned to make some of these transitions in our rule volume and as a state. So the 4th edition of the ASAM criteria requires co-occurring capability at a minimum for all programs. This aligns well with our existing expectations and the updated provider rules among, in multiple places, but definitely including our definitions, our substance use disorder treatment and mental health equivalent structure that was just a couple of years ago, this will really lean well into supporting this. But this is built upon the expectation that the majority of individuals who are receiving services for a, oh, heard something, sorry. Sorry, I don't know if you all heard that. It just said something joined the meeting. Maybe it's just in my ears, I'm not sure. So the expectation in the 4th edition of the ASAM criteria is that it is more the rule rather than the exception that individuals receiving substance use disorder treatment services have a co-occurring condition, mental health involved condition. It's really helpful to address both of them at the same time. So the expectation is that at least one staff member of programs are able to assess and triage for mental health needs, that there would be coordination with mental health specialty providers if not available in-house or in your agency, and that mental health involved needs are integrated as part of the treatment planning process. So hopefully moving in that direction of treating the individual and not necessarily bifurcating SUD and mental health involved. Another update that is going to be applicable to all programs is the inclusion of recovery services. Again, this aligns really well with the updates that we had from the updated provider rules only a few years ago, where we were able to write in Chapter 3 recovery support endorsements and expectations, and really elevating peer support professionals and utilization of that lived experience and recovery in moving individuals forward. So again, be required for all levels of care, and it's essentially a collection of services to provide practical support for continued recovery, a lot of times delivered by allied health staff, which is going to include peer support professionals, patient navigators, health educators, and so on. This includes things such as peer support, life skills practice, navigation, transition planning. So it really does lean well into the direction that we were trying to go in elevating this type of service anyway. Another expectation that is written into the 4th edition of the ASAM criteria is that all levels of care align and really take an approach that is emphasizing harm reduction. Again, this fits really the expectations that we were able to write in a couple of years ago, which we're very excited about, where we actually have harm reduction that was written into the updated provider rule, which was a big win from where we were before. Also, part 2.27 that was written in expectations around having an opioid antagonist available on site and really pulling in individuals' support systems and making sure that that is a way to make sure that harm reduction is elevated and part of our regular presence. So we do have a good foundation for that as well. This will be required for all levels of care and is intended to reduce negative consequences for substance use, really acknowledging more than one way to recover, promoting individualized care, and really widening the definition of success for individuals. So here we're going to talk a little bit about another expectation that is added in, and this goes a little bit into a deeper dive that we're not going to get into today. This will be more for a later meeting that we have, where we really walk through some of the other changes that happened to the ASAM criteria in the 4th edition around dimensions and assessments and all of that kind of stuff. But this is really important to highlight because the 4th edition of the ASAM criteria really highlights the need for addiction medication access and really elevating that for individuals. So I will say that Dimension 1 has been updated to include a measure for addiction medication needs. And leaning into what this looks like for our residential discussion today, will include specific physical examination requirements within specified time frames depending on the level of care, right? So it's essentially saying that individuals need to, we need to prioritize getting a physical examination for addiction medications, depending on the level that you're providing, either very promptly, as you can see for 3.7. It's going to be a much faster timeline that would be for, say, a clinically managed 3.1 or a 3.5. 3.1 is intended, 3.1 and 3.5, really the intention is to make sure that this level of care can support medication continuation of FDA-approved medications for SED treatment, And then moving into medically managed 3.7, the intention is to be able to initiate and titrate these FDA-approved medications for SUD treatment. So an exciting direction as well. Care coordination. Again, this aligns really well with a lot of efforts that have happened in the past couple of years. Just a couple of them just to highlight here, the addition of warm handoff and safety approvals in the updated provider group, right? Really leaning into creating a network and making sure that individuals and providers are able to link together to ensure the individual receiving service is not falling through the cracks and getting what they need. So this will include basics of care coordination, right? Establishing accountability, clarifying responsibilities, communication, transition assistance, monitoring and follow-up, and linkage with community resources. So again, elevating this to an expectation in a more tangible way. So let's take a second here and we'll look at some universal residential standards that are going to be written in for the 4th edition of the ASAM criteria. Again, highlighting that we do have some things that were updated in the provider rule a few years ago that really do start to lean into laying the foundation for this in a positive way, such as our living space assignment. So all sites and residential levels of care need to have the space for clinical services, all the different ones that we have listed here: rest and privacy, meals and hygiene, substance-free environment supporting individual dignity, privacy, and security of personal belongings, acknowledging also that we need to have trauma-sensitive practices that are in place that can also include safety searches, right? As long as things are completed in a way that supports the individual's dignity and ensures the safety of the physical space. And then the layout allowing supervision and timely personnel responses. Okay, so since we're talking about residential involved needs today, I do want to take a minute to highlight the therapeutic milieu and how this is written into the 4th edition of ASAM, because we want to make sure as we're moving forward, that is one of the very unique things that the residential programming can provide for individuals is the therapeutic milieu. So again, we have this written in that wasn't explicitly there a few years ago, so we have a good foundation to move this forward. Therapeutic is going to be our structured environment where individuals learn from and support one another, focusing on practicing and building skills such as asking for and accepting help, building pro-social skills and support networks. So, and it's going to be, the intensity of the milieu is really related to the level of care that you're providing, right? So 3.1 will have a slightly less intensive milieu versus like a 3.5 that we'll talk about here in a few. Okay, so we're gonna go ahead and look at residential staffing standards. So all residential levels of care in the 4th edition of ASAM are required to have is very much aligned with a number of the permissible, like group living workers would be one example, or peer support professionals, different groups of personnel that we already have as an option for our coverage of facilities. So that's moving in the right direction here. And as you can see here, we have a little table where it talks through allied health staff being on-site and alert 24/7, nursing staff being on-site and alert 24/7, and medical directors and whether or not they are required for particular levels of care. 3.1 versus 3.5 and 3.7, we're going to do a number of kind of tables like this throughout this discussion where we can pause and talk through some of the different expectations and kind of how it might look a little bit different than it does today. Okay, so continuing to lay a little bit of foundation here before we start diving fully into the differences and distinctions. We are going to talk for a second about one of the distinctions that in the 4th edition of ASAM, we are leaning into definitions of clinically managed versus medically managed. And this, again, is one where we have the foundation that is laid. We had it started with the updated provider rules that we had there of really having clinically monitored, clinically managed, medically monitored, medically managed. So we'll be able to adapt this hopefully fairly simply from that side and be able to lean into what we already have started. But the way that this is defined is clinically managed is where treatment services are primarily overseen and delivered by clinical staff. This is going to be our level 3.1 and level 3.5 for the residential possession. Medically managed is anything that you see in the, I'm going to go through our continuum here, that ends in a 0.7 is going to be considered a medically managed level of care. So these programs are focused on treating withdrawal, intoxication management, stabilizing biomedical and psychiatric concerns, while providing the full spectrum of psychosocial services, right? So from the lens of looking at our residential levels of care, this is going to be our 3.7 level of care. And I can see there's a lot of chats that are coming up here, and we'll get there in a second. Let's get through a couple more slides and then we can pivot back over. Okay, so this visual we're going to walk through on the left-hand side, current state, third edition standards. All of these residential levels of care are ones that are eligible as endorsements for providers across the state. As we're moving into the aligned state with the fourth edition, you're going to see that it is a simplified model for the residential services continuum. So 3.1 has essentially moved over very similarly to not a ton of changes, and we'll get into depth with each of these here in just a second, but mostly a lateral move into clinically managed low intensity services. ASAM 3.2 withdrawal management has a little dotted line moving over to the 3.5 clinically managed high intensity. That is because this level of care in the fourth edition does not stand as its own standalone services, and instead the expectations of a 3.2 withdrawal management as far as being able to handle intoxication and withdrawal management services are now embedded within an existing 3.5 residential level of care. 3.3 as a standalone level of care does not exist in the fourth edition of the ASAM criteria, and instead the assumption is that very concrete interventions that would be appropriate for cognitive impairment can be embedded within any other residential level of care, and that the program would respond appropriately to that. And then 3.5, again, a lateral move over, that remains our clinically managed high intensity program. And again, we'll go into some of the details of the 3.5 here in just a minute. And then very similarly, that 3.7 withdrawal management no longer operates as a standalone endorsement or a level of care, and instead that the services provided by that level of care are embedded within a 3.7 residential facility. And then again, 3.7 laterally moves over into our simplified residential services continuum, 3.1, 3.5, and 3.7. Okay, so this one, this is a higher level just to show what the updated continuum of care looks like in the fourth edition of ASAM. So I'm not going to spend a ton of time on this slide, just wanted to be able to show this is a visual of what this looks like on the larger scheme or larger scale of the continuum of care. Okay, so again, I'm seeing that we've got some chats here. Let's go through a handful of clinically managed residential treatment slides. A quick time check, we are at 12:40. Okay, so as previously mentioned, we 3.1 and 3.5 are classified as clinically managed residential treatment in the fourth edition of ASAM. And again, that means that clinical personnel are the ones that are responsible primarily for overseeing and driving care. So let's start talking through level 3.1. So what we have here is we're going to highlight on these slides notable changes when we're looking at transitioning from the third edition of ASAM into the fourth edition of ASAM, only for this particular level of care. We're going to do this across the board with the different residential levels of care, and then we'll also have slides where we're going to kind of do a comparison of 3.1 compared to 3.5 compared to 3.7. So we'll have a minute to look at them kind of in that the larger picture. So for a 3.1, the most notable change that we wanted to highlight today is the clinical service standard, or the hours that are required as part of a 3.1 level of care have increased. So our current state in the third edition of ASAM, a minimum of 5 is permissible. And as you can see here in the fourth edition, that has increased to 9 to 19 hours of clinical services required per week. So one of the reasons that this was done was to prevent sharp drop-offs in the amount of treatment hours that individuals received. And so what they did here was align the clinical service hours of this 3.1 with IOP 2.1 services to make sure that they are receiving the same number of clinical hours per week. And again, this 3.1 distinguishing factors, they're really providing additionally that residential structure support that's so important. So then the other explicit change that is listed in the 4th edition of ASAM 4.1 is structured services are 7 days per week. So a number of our programs are probably close to that, and then there are some that don't necessarily have them split and available on the weekends. But that is something that we would need to work into the 4th edition standards and needs to be offered 7 days a week. Otherwise, 3.1 services are very similar to what they are in the current 3rd edition. Okay, let's go ahead and jump into 3.5, knowing that this is one of the more tricky changes that we have moving into the 4th edition. So notable changes that we want to talk through here. Clinical service hours have increased, very similar to how they did on 3.1. These were increased to align with partial hospitalization or level 2.5 standards. So 3.5s in current state, subject to the 3rd edition, the minimum is 10 hours per week. With this shift to align the standards and the clinical service hours, this now goes to 20 or more hours of clinical services available per week. So that's a pretty significant jump for a number of our providers. So that is something that we will need to consider and see how that could be operationalized. Then the other part to highlight here that is very specific to 3.5 is they're providing residential supervision in addition to the structure and support of that residential milieu and environment. The same expectation was put in place and explicitly stated that structured services are required to be available 7 days a week. And then the unique shift here that we want to talk through is 3.5 now requires a medical director to be part of the staffing pattern at a 3.5 level of care and requires the facility to be able to provide on-site withdrawal management services. So we'll talk about that here in just a second and walk through some of the verbatim expectations. But this medical director is intended to be able to develop, approve, regularly review admission processes, and to oversee appropriate placement and provide on-call medical support as needed for individuals that are undergoing withdrawal management on site. So this should allow the potential for directives into a residential facility, individuals who may be intoxicated or require withdrawal management type services, and also allows individuals to remain in that program in case of a lapse or a relapse. They do not have to leave that facility in order to have that intoxication managed and withdrawal management initiated. They can stay where they are and continue in their residential services. So one of the things that I want to highlight in looking through tons of resources put out by ASAM about the intention of putting this together and kind of moving into this direction was continuity of care for withdrawal management was determined to be critical. Patients that are receiving withdrawal management services without kind of that regular continued engagement in substance use disorder treatment care, it results in a lot of negative outcomes, or potentially could result in negative outcomes, including mortality. So the concern was having those two separated potentially raises the risk for individuals and does not necessarily encourage or continue their engagement in substance use disorder treatment. So this is meant to be a safe way to manage individuals in community, also ensure that they are continuing in services and recovery. Okay, so let's look at this one here for just a second. So withdrawal management in level 3.5, this incorporates, again, those 3.2 withdrawal management involved standards and capabilities into that residential program. But one thing we want to highlight is that it does not require these residential programs to begin operating as 3.2 withdrawal management would, right? And it sounds like that might have been confusing. We want to make sure that it's clear that that doesn't mean that 3.5s need to start accepting programming. Instead, what it's doing is it's allowing that residential program to be able to support individuals that would be directly admitting or potentially staying on site if in case of a lapse or relapse. So at a minimum, this is going to include 24-hour supervision, observation, and support for intoxication or withdrawal in scenarios where the individual does not require medically monitored or managed care. And this is determined by the medical evaluation. So this will also involve supervision of self-administered medications for withdrawal management that are operationalized either through prescriptions, or prescriptions from a physician, or Italy would in a 3.2 withdrawal management just in this residential facility, through physician-established protocols, and really looking to see if we reach a point where that individual requires medical consultation or transition to a higher level of care. And then the psychosocial services designed to support the completion of the withdrawal management process. Okay, so then looking a little bit further, and then we'll pause and check in on the chats and have some discussion. So who is the medical director? So per ASAM, this is almost verbatim. The medical director is a physician or advanced practice provider with at least 2 years documented experience in specialty addiction treatment. It goes further in defining the advanced practice provider as a non-physician healthcare provider with a scope of practice to provide medical diagnoses and treatments, including but not limited to PAs, nurse practitioners, certified psychiatric mental health clinical nurse specialists. And in this 3.5 program that we'll be transitioning into alignment with, the medical director does not need to be an addiction specialist physician, although the agency will need to have policies for consultation with that specialist as needed if the MD medical director does not hold those credentials. So one of the caveats that is present in the ASAM for this is if the agency is unable to find someone that meets this criteria after, quote, a reasonable effort, and we'll have to see what that is, right, and make sure that we're moving forward together with that. A physician or advanced practice provider who meets competencies as they are listed in the 4th edition of ASAM in one of the appendices can serve as the medical director and should have an established mentor who's connected, who's board certified in addiction medicine or addiction psychiatry. So there is an awareness and acknowledgement that this is where we want to get to, and if after reasonable efforts we cannot quite get there, there is a plan B for being able to try to achieve this, this concept of being able to remain in community safely, have intoxication and withdrawal management handled, recognizing that this is a for a lot of our residential centers. Okay. So I am going to go ahead and just high level, I'm just pulling up this comparison between 3.1 and 3.5. This really does a good job, I think, of highlighting some of the distinctions between the two. Number of clinical service hours, that's a main factor. That is provided for the 3.5 level of care. The distinguishing factor, and again, the medical director in 3.5 with the ability to handle that withdrawal management need on site. Okay, with that said, I'm gonna go ahead and go to a holding slide for questions. I'm gonna do a quick time check. We are at 12:50, and I'm seeing, I wonder if anybody on BHA or HCPF side might have an idea of where we might want to start with any of the questions in the chat.
Mariana,
Not, I can try to catch back up.
So I got a couple folks at the beginning there and said, hold with your question. It's a great question. We're going to get to that in a second. So I'm going to skip over those and I'm going to start with Crystal. Hi, Crystal. I have your comment is several significant barriers here that need to be discussed, impacting providers, infrastructure, milieu spaces, and beds, cost, timelines, etc. Crystal, would you like to come off mute and speak a little more about your concerns here?
Sure, thanks, Mel. And any other providers, please, chime in as well. So I think for Sobriety House in particular, we would honestly have to give up treatment bed space in order to accommodate someone in active intoxication or withdrawal, because we cannot mix those populations. That simply is not going to work. It is triggering for our other clients. It's not possible. So also, I'm still kind of confused by the clinically managed level of care requiring a medical director. So I don't know if that question has really been answered. It is pretty costly to have a medical director as well. And so if the expectation from the state in these timelines as sort of an unfunded mandate, if you will, it's not that we're not willing or any of those things, right? Like, I just see so many impossible barriers that it's causing a lot of anxiety. We'll put it that way.
Thank you, Crystal. I think that in the face of a significant change there is a lot of anxiety. There are still a lot of unknowns and variables that we just haven't been able to answer, or really being able to look at right, some of the things that make this amount of change more palatable or less intimidating. We're not there yet. And so I will say with this, we are working in class to be putting forward these expectations of clinically how we believe that this could be done regulatorily, and how can we have this in a sustainable way. And then HCPF will be looking at this with us, right, to make sure that that rate reviews as part of this process, right? This needs to build into a sustainable model. And so we are absolutely looking at that. We're just, yeah, I share the concern, and I appreciate the vulnerability there with sharing that, Crystal. I see your hand again.
Yeah, sorry. So just one more thing. I'm hopeful that Colorado will be able to sort of collaborate or look at other states that are already a little bit ahead of us with this, and have some flexibility with the ASAM 4th edition requirements, rather than it being all or nothing if it doesn't work. So for example, with community partnerships, I'll use ourselves as a specific example with Denver Health. Like, we already have a very established official partnership. They have a facility for withdrawal management already. And if we can somehow be within the guidelines of ASAM 4th edition, we could implement this tomorrow without a problem, right? Like, but if the expectation that withdrawal flexibility with community partnerships or something like that could be implemented or considered, that would be really helpful.
Awesome. Thank you for that, Crystal. So I think part of what we're getting into there is needing to be able to button up that discussion about formalizing withdrawal management and intoxication management in the crisis space, right? I think what you're describing there, and that partnership and being able to, being able to operate in both spaces, is the direction that we think we can go and still have a sustainable model that recognizes the urgent and emergent needs and what that intoxication management provides in the crisis area, but also allows our residential providers to be equipped to be able to handle it as well. So I would definitely say, if at all possible, let's take parts of that discussion. We'll absolutely take this feedback and the related chats that we have, and that is what we're hoping to close out together in the discussion for March 25th. Leans directly into that. Okay, so I think then I'm going to take a second, and I'm realizing the way I have my screen, I can't see faces at all. I can't see anybody, which is kind of hard because I can't see any reactions, and that's on me. But I wonder if I might be able to lean back into Mel. Would you be able to keep me on track with where we should go?
Absolutely. We'll go next to Angie Wold. Angie says, is the BHA able to provide additional funding to 3.5 providers to implement these changes? Adding medical personnel is quite costly. And I'm looking, I don't believe we have Mark Condajani today. Mark is let's see, do we have Mark today, Mariana?
I am not sure, actually.
Well, I will just add, this is Angie. I'll add, I mean, if you're gonna require a medical director, maybe they're not full-time, but if they are and they're an MD, addiction medicine, I mean, you're looking at over a $200,000 salary plus benefits. And I would say most providers probably aren't cutting it now. And so then you're added this on in addition to personnel that are going to be have the right credential to provide 24-hour supervision for detox. And it just, again, if there's not an increase in rates, there's no way people can do this, and you're going to drive providers out of the business.
I appreciate that additional feedback, Angie. And this ties into the comment below you from not Trisha Carson, but from Lee Merrifield about something that we need to check on in terms of nurse practitioners being able to operate as a medical director per the Colorado Board of Nursing. So while ASAM 4 has some additional folks that are not a physician with that specific addictions background for that 3.5 level of care medical director, we want to make sure that we are that we're providing as many opportunities as possible to make it as easy as possible to hold that medical director position for our 3.5 providers, since we do have to match statutorily the ASAM 4 criteria. Dr. Rob, I see your hand up, so I will pass it over to you.
Yeah, hey, so I would say sorry, let me lower my hand. It's gonna distract me. I think we're past like arguing over this, or for us, we know it's going down. We have concerns, we've voiced them. We just want to know, I think at this point, what services are going to be available to us to get this done, to move forward. What kind of support can we expect? What kind of help can we expect? What kind of probationary periods will happen during the change, like once we implement, because I could assume that all of us are going to wait till the last minute. And then I put in the chat, for us, it's crucial that we have the BHA educating our hospitals and our communities, especially our hospitals. They're going to feel abandoned by us when we pull away the 3.2, and that could be a public relations nightmare. They're going to police are going to be deflated when they call our phones and they can't send them to us. Our 3.2 withdrawal management does like 185 people in El Paso County. The hospitals are going to feel abandoned, and the clients that come to the door and knock to turn themselves in, they're going to feel abandoned. So for me, this if the BHA could take out ads in the newspaper or TV saying like, hey, these are the changes we're implementing. This isn't a crossroads thing, because they are going to be hurt. They are going to be abandoned. They are going to be let down by us. And I think that it's okay. Change happens. We're moving into the future. Everybody wants the best bang for buck. We're all in the business of saving and changing lives. And that's what we want to do. If this is the best vehicle to get us there, we're not going to fight it. We're going to get on a surfboard and go with the waves. But in the meantime, the community is going to have it's not just us as providers that have opinions about it, but the community is going to have opinion about it. And I can imagine it's going to be pretty hectic when this all goes into effect.
Thank you for that, Dr. That's, it's popping in. So I will just say real quick, I think that's exactly why this next month and able to really make our, the idea of codifying and really formalizing a safe withdrawal management and intoxication management in the crisis sphere, and making that available on both sides will hopefully help to move us in the direction of still supporting the community and being able to be the messengers, right, of that information. And here's where we're going. So absolutely, we are still planning to do that, and we will be working with you directly on that as well. Jennifer.
Yeah, I just also want to say thank you for raising that point about messaging to just Coloradans in general that might want to use these services. I think that's an excellent point, and we certainly do stakeholdering in that space. And we just give a little plug that one of the things that we need to that we do every year and are happy to promote, maybe adding this as a focus, is our 11:15 SUD demonstration requires that we provide public and specifically invite Medicaid members to join and participate and listen about what we are doing in the SUD treatment space. And that is one place, but I certainly think we need to find others where we can start bringing that message this year forward, as we have. What are the alternatives? Because I think that point for the community to understand where do I go is a really important one. So thank you.
Awesome. Thank you for that, Jennifer. So I'm wondering, I see that the chats are still coming through, and I want to make sure, just a time check, we are at 1:01. I know we have until 1:30 today, and we still do want to be able to at least level set the 3.7 and what those expectations would be. I wonder if it might be wise to just continue getting through the 3.7, so at least we have that information, and we'll continue to gather this information and be able to report back hopefully at the end of this. So with that said, and Mel, I'm going to say, is there anything else that is very pressing that you're seeing that we need to address right now, versus trying to make sure we get through?
Well, everyone's comments and questions are so incredibly valuable and valid. I do want to make sure that we get through all of our material. I know that this is a very heavy topic with lots of questions and lots of things that are still being determined. And so a lot of the questions that are still coming in the comments, unfortunately, we don't have responses to right now yet because those systems are still being built. So I think right now, let's go ahead and move forward with the 3.7 items that we do know, because we're having to take them from ASAM 4. And all of your comments and questions that you put in the chat, and when you come off mute to speak with us, those are all being recorded. So it's all things that we are keeping track of and making sure that we are keeping in mind as we are starting the drafting process. So Marianne, I will hand it back over to you.
Thank you, Mel. And just a quick check, I had stopped sharing my screen so that we could see each other with that question and answer section. Does it look okay? It should be showing medically managed residential treatment. I see Mel nodding. Okay, perfect. Okay, so let's go ahead and proceed with this. We are going to focus now on shifting over to the last part of our residential continuum in the 4th edition of ASAM, which is medically managed residential treatment, or level 3.7. So again, highlighting the notable changes that we want to make sure we level set here today. The most significant one is going to be that 3.7 level of care needs to have the ability to have 3.7 typical 3.7 withdrawal management type services embedded within that level of care. Again, the intention is to make sure that that this is safely managed, and then really encouraging of continued treatment and care, and continuing the individual along the continuum of services in their recovery path. So this will require the 3.7 provider to have immediate access to addiction medications, which would include MOUD involved medications, which may be best achieved by a controlled substance license to be able to have stock medications that are available on site. I do want to say before, and I forgot to say this earlier, one of the things, I'm not sure that our state opioid treatment authority was able to join us today. He was triple booked, actually, and I don't see him on right now. And so I did let him know that we're going to share this. Oh, are you here?
Mariana, for you, I'm here. Sorry about that.
Yay! Oh, you just made my day. Your square says Valerie, so I did not see you. So you tricked me.
You know, we all like to pretend to be someone else sometimes, and I'm lucky enough to pretend to be Valerie Resendez today. So I'm having a great day.
Yes. You picked a great one. She's fantastic. So, okay, so Ryan is here. So we can hopefully engage in a little bit more of a conversation, again, being mindful of time and keeping that in mind. If there are comments that we don't get to, same plan, we're going to gather all of this information and it will all be responded to in some other venue if we can't get through it today. Okay, so knowing that we have Ryan, we will continue. The other notable change that we want to highlight is, again, building into that connection for recovery support services. And again, we already talked about this as being applicable to all levels of care, but this one we wanted to highlight a little bit differently just because this is a bit different from what we have in current state for 3.7. So it's just kind of adding a little extra note to it to make sure that we're drawing attention to it. Other than that, it's a fairly similar expectation to current state for 3.7 residential levels of care. So the staffing expectations, again, per ASAM 4th edition, are direct staff, a medical director, having physicians and advanced practice nurses on staff, as well as nurses. Explicitly say for for the remainder of the psychosocial elements that are part of the 3.7 residential level of care, they can either be provided directly or through formal affiliation to ensure that the remainder of the staffing and the services are achieved. So that would be program director, clinical staff, and again, those allied health staff being part of that. So as we saw on the slide before, the nursing staff are available 24 hours a day, 7 days a week, on site at all times. And it does have physician and advanced practice providers available on site or via telemedicine 24/7. So I do think we to lean into some of the updated guidance in the 4th edition of ASAM that allow telehealth to be permissible as long as it is done in a safe and ethical manner. All right, going to the next slide. So just a couple of the related elements for addiction medications in 3.7 we wanted to highlight here. A timeline for a physical examination, again, to ensure that individuals are receiving access and aware of medications that will help stabilize and engage them in their recovery process within 24 hours of admission. That 3.7 level of care is meant to be able to support that initiation, titration, and continuation of addiction, again, in alignment with the current best practice. It does speak a little bit about the preference for injectable medications to be available on site, and this is one that we do want to highlight as this would be different than what we have in current state for specifically our controlled substance license. But since Ryan is here, I can say that when we were talking about it this morning, he did mention that this has been helpful for programs when it was available. And so this is something that we would need to look at as a state together going forward if that would be required. It also has the expectation that education about medications to assist is provided, and that's something that we do already, but we'll make sure that stays forward. And again, highlighting that partnership of a controlled substance license with a 3.7 level endorsement is likely going to be the most efficient way to achieve this expectation of immediate medication assistance for individuals in this level of care. Okay, so continuing here, level 3.7, the support systems that are identified in the 4th edition of ASAM to ensure that 3.7s are functional. Medically managed levels of care, going to need, again, that building that care question, but specifically it does focus quite a bit on methadone treatment providers, so OTPs, unless they're not locally referring for specialized clinical consultation needs, right? So infectious disease specialist, if there's somebody who's pregnant or parenting, obstetricians, etc. Supporting access for prescribed medication, referring for primary care services or providing them directly there, conducting or referring for laboratory testing and for drug testing and toxicology. So again, it's really leaning into building that network and making that part of the base expectations is that this support network is in place to really be able to provide individualized care for any individuals that are in that level 3.7 care. And then just going a little bit further into some of the expectations that are written in for 3.7 medical services. So being able to handle intoxication, withdrawal, biomedical, and psychiatric care. That comprehensive exam will include both the medical history and physical exam, as we talked about. Nursing assessments on admission, again, that's already present in current state, so hopefully not too much of a lift to move to that as well. 24-hour nurse monitoring, it does say hourly is what the expectation is. Medication management, and then prescription services with those essential medications available on site, which again, right, could a lot of times be achieved by having that controlled substance license potentially and having a stop if prescriptions are not immediately available. Okay, so then this is the last borrowed slide from ASAM that I wanted to put up here to really kind of show that context of 3.1 versus 3.5 versus 3.7 and some of the distinguishing factors here. And I want to give it a minute so that folks can take some time to look at this and kind of process if this is helpful for that larger picture of this is what the residential continuum of care will encompass going forward. Okay, so with that said, I am looking for my chat to disappear. We'll find them in a second. I have some time here for a few more questions before we do kind of wrap up of next steps and where we are going. So I'm going to see if I can find my chat to pull that back up. And in the meantime, open the floor if there is anybody that wants to come off mute and has any questions. I'm definitely welcome that.
Like anybody would like to come off mute right now, but would you like some assistance with running the chats?
I got a quick question.
Sure. That was nice because I got, oh, yes, go Paul.
Yeah, so like I had mentioned in the chat, I got some serious concerns about the requirements of 3.5. I mean, you know, we have a detox, we have one and there's one 20 miles down the road. And for us to find two medical providers that have that kind of experience to be able to admit people for a very large region, you know, we cover 6 counties, 10,000 square miles out here. And some of our emergency rooms have 2 beds, you know, and they can't be keeping people detoxing in there for that reason. Secondly, unfortunately, some of these folks may end up in jail, which, you know, is not a good thing at all. So that was just my comment. My question is, do you think there'll be waivers available for this?
That's a great question. And thank you so much, Paul, for your feedback there. So we are still developing, particularly around one thing that we're exploring is what does it look like for intoxication management versus withdrawal management when we're creating that behavioral health crisis care model when it comes to you know, a receiving center. We've called it a lot of different names in several of these meetings about 3.2 transitions. So as we're developing that, that is something that we're looking at is what is considered to be falling under that statutory mandate of we have to be aligned with the latest ASAM standards versus what can we be flexible around. So I cannot speak to, you know, yes, this will be waiverable or no, it cannot. It really is going to come down to what the waiver committee decides in terms of what has that flexibility. And I saw that Jennifer came on camera, so I didn't know if you wanted to add anything to Paul's comments and questions.
I guess I would just caution everyone to recognize we haven't yet really moved to focusing on reimbursement, but when reimbursement is set, it will be based on meeting criteria. So when we start talking about what gets waived, then you're impacting reimbursement. just flagging that.
Yeah, I appreciate the feedback. I know that there's not a lot of answers to questions right now because it's a process, but I think a lot of us may be just commenting to just, put that information out there as questions that can be asked as we move through the process. So.
Absolutely, and I appreciate that. And I mean, similarly, I read, everyone's comments and questions here. As I said earlier, unfortunately, a lot of them we still don't have definitive answers yet as we're developing the system. And, really it's just coming down to it's time for us to put, the, virtual pen to paper, since we're typing it all in a laptop. So that we have something to bring back to y'all so you can actually react to it and engage in a different level of stakeholdering where we're out of informing about the changes and what is to come, but actually reacting to the drafted rules themselves. And I just saw Sydney, fabulous question. When do we think we'll have definitive answers? So this aligns actually with Mariana's talk around next steps. So Mariana, I don't know if you want to go ahead and provide that information, and then we can come back to any additional questions or comments.
Sure. Let me see if I can share my slides correctly again. Hopefully it works. Okay, so let's go ahead and do a little bit of next steps, and then we'll make sure that we have kind of a nice buttoned up way to end here today. So again, just kind of a plug that this was very much focused on kind of those general residential expectations moving into the 4th edition. And we do recognize that criminal justice focus, we have a lot of partners with community corrections residential facilities, as well as Department of Corrections having a number of facilities and programs that we're going to need to look at this separately. So again, looking for wins wherever we can get them. The good news is we do have a number of a decent foundation that was put in place with some of the updated provider rules, adding in risk, need, responsivity, promotion of individualized care, collaboration with the supervising entity, and updated provider rules. So again, we're going to try to move this forward with this upcoming rule process, but also anticipating and expecting that there is a future rule volume that will be focused on reentry expected in 2027. So this process is intended, this is going to be over multiple years, and when different volumes come out, we will have to readjust and continue this discussion and this dialogue as those new standards are written in. So right now, things are focused on this adult volume 1. The next one that is intended to be released by ASAM is going to be adolescents and transitioned age youth. That is supposed to be early 2026 is the last that I heard, right? And so this will be a continued work in progress over the next 3-4 years or so to finally get into full alignment once those standards are provided to us. So please keep that in mind. This is not a one and done. There are things that we will try to lay the foundation as best we possibly can, and then we can always come back and revisit them to make sure that we're building the best possible system. So then just to have a couple of links here as far as next steps with about 10 minutes left here. The request will continue to be, please be curious. Please take some time to look at the ASAM website if you have not done this already. They do have a number of really helpful resources, a lot of which will look familiar based off of what we just went through here, pulling some of their simplified guidance into bite-sized pieces to be able to walk this forward in a way that will move it forward without kind of paralyzing that progress. So we do have some additional guidance and details that will be coming. I know that there's a number of providers who were waiting for a wrap up from our January 28th discussion. There were some kind of myth busting and different questions that came up that we said that we'll get back to you about, and we are still intending to do that. There have been moving parts and pieces behind the scenes that we want to get that correct information and be able to share that with everybody at the same time. So that will be coming via email this week. And another plug too, please register if you're not already registered for the Withdrawal Management and Crisis Services Continued Discussion, March 25th at noon. That is intended to be where we'll be able to button up that part of the discussion, and then that will lead into the month of April, right, where the majority of the rule drafting is going to occur. I know I saw a question about where is this information being compiled. So our landing zone continues to be the BHA laws and rules page. And we are starting to, as other existing rule processes are moving forward, that should start to be cleaned up on that website so that the ASAM involved stuff will start to expand and be more of a priority presence there, especially as we have rule language that is ready to be shared and reacted to. So please bookmark the laws and rules page. That is where this information will continue to be built out. So I think going back to the question of, I can't remember who had asked it. So let me see if I can find it. Sydney, when do we think we'll have the definitive answers? Within the next few months, we will have rule language that can be reacted to. So I think giving that timeline of focusing this month and a little bit of next month in that residential and crisis withdrawal management, really buttoning up that into here is the proposal and here is how we think this will achieve all of the expectations, right? Incorporating ECIC, where is that going to live? How is that going to align with statutory changes that might need to happen and different things like that. So within the next few months, you will have rule language that you can review, that you can react to, as well as resources that will help to to show what this updated endorsement structure will look like in this proposed transition into the 4th edition. Okay, that was a lot of information. Let's see, and with that, I think one other thing to highlight is, as mentioned, right, this is not a directly linear process, right? We don't just achieve one thing and then move on to the next one. We're working on this at the same time we're working on this and this and this, right? There's a bunch of different things that are happening. And that includes working with HCPF to look at the rates and have that be part of that process. So we will continue to engage and provide that information as we are able to, and understand that a number of this kind of base foundation with the rule language and different parts around that structure need to be in place before HCPF has the chance to really look fully at those rates and engage in that discussion in a way that they can come back with something that's tangible for folks to react to. So know that's hard to say because I know that we wanted these answers a long time ago and we still have to wait a little bit longer. But I assure you, we're going to do the best we possibly can to share that information as soon as we are able and often, and come back to it. So I think with that, I'm just going to pause on the closing slide to make sure that folks have our BHA rule feedback email. So this one is monitored by multiple folks, and this is where we are gathering and just kind of saving any information or feedback that we have that can be incorporated hopefully in this first draft of rules. If we're not able to address something there, we still have record of it and then it can be addressed future state. With that, time check status. And again, I'm so grateful that Zoom keeps track of all of those so we can make sure that we have all of them and don't have to copy them over. But I wonder if I might be able to lean into Mel one more time and see if there's anything else in these last few minutes that we have together that we want to pause to discuss.
Sure, actually, I would like to hand it over to Jennifer Holcomb with HCPF.
Hey everybody, me again. So yes, I do know that there's lots of concern about what reimbursement rates will look like. And while we can't actually determine how HCPF values everything until we actually have more solidified the rules. Obviously, we are working in close collaboration with the BHA, and we have a pretty good sense of who's going to need to do what where. So we are starting in that process, and it is a lengthy process because, as all of you who are providers know, for the SUD benefits, you actually negotiate your reimbursement rate with the raise that you contract with, but the department does value services to figure out how the department compensates the raise. So while we do not directly set rates for providers, obviously our approach to how Medicaid funds these services impacts the rates that providers negotiate with Raise. And we are beginning the work because a lot of the same work that you need to do on your side as providers to think about that crosswalk of what types of providers would we need to add if we want to move to this level of care, or what services or what storage do we need to have if we want to move to that level of care. On the HCPF department side, to figure out how to value all these things, we are doing similar kinds of crosswalks to say, what will the level be? What are the new things that will be added to that level? What is going away? And it is all pretty complex calculating for us to get started. So just want to reassure everyone, we are working on that, and we are not going to be at a point till we have draft rules to be able to then start matching reimbursement to rule. But yes, we are working toward the same end because it will take quite a while. So appreciate everyone's patience, but yes, we are working on it.
Thank you so much, Jennifer. And I think Lauren's still on. Did I see that you had a hand up there for a second? Okay. I just wanted to give you a chance just in case if you did have a hand up. I know there have been several questions around what type of funding does BHA specifically have to support these endeavors? I know in the past, our interim director of programming, Mark Kanajani, I don't think that's his title, but that's what we're going to say it is right now because I can't remember what it officially is. But he has spoken about some contingency management, and we did do a survey with our 3.2 specific withdrawal management providers to gather what some of those change costs may be. So it is something that we are looking into, but I don't, unfortunately, I'm a broken record here. We don't have any definitive answers of what kind of additional funding opportunities are through the state at this time. And I'll hand it back over to Mariana. Oh, hi, Mariana. Actually, I see that Zach just raised a hand. Zach, would you like to come off mute?
Hey, I'll just say this. I think it would be good on the laws and rules page to address, as far as like the kind of full steam ahead. I know there's been a lot of meetings already where it's like, yeah, we're going with 4th edition, but as far as like whether at this point in the road alternative models will be evaluated, or if not, I think that lets a lot of different stakeholders that are just kind of jumping in, because it does seem like a continued question of whether there will be a diversion to like try to be creative in a different type of way to potentially retain withdrawal management. So I think that would help, because obviously we're getting right around to the BASO stuff, and to implement these changes, there's been conversation of potentially we would see capital funds, or we might not. And so I think a lot of those things need to be shown early on so that providers can start positioning if, we're past the point of quote unquote no return.
I really appreciate that feedback. And I know that with HMA coming on, that one thing that they will assist with is they're going to be developing like a frequently asked questions document, and that will definitely be, if not number one, a prominent figure on that document. But we can also link that on the BHA laws and rules web page as well. I do want to circle back around to the statement around looking at alternative solutions. I just want to reiterate that with the way that our state is set up through the 1115 demonstration waiver and statutorily, we do have to align ourselves with ASAM 4. And so we are looking at creative solutions within those boundaries, and interpretation within those boundaries, but we do have to align with ASAM 4. So that that is a hard boundary that we have to hold. So, but I really appreciate that feedback.
Cool, thank you.
Now I will hand it back over to Mariana.
Okay, we are officially at 1:30, right up to the last minute, and got some action items absolutely in there. Thank you everybody for your participation. We are absolutely going to be working on bolstering that laws and rules page to be able to cover these discussions and really lean into some of the questions that are still out there. So thank you so much for your time, and we look forward to engaging with you, and hopefully we'll see you on March 25th at noon. Thank you all.